Good morning, everyone. Good evening for a lot of people. Good afternoon for a lot of people which are joining from various countries. We are on 62nd session of International Speaker Forum in association with SIMAO. We have been bringing a lot of various topics which are relevant during this pandemic time. Today, we have another topic from again USA, the impact of COVID-19 on mental health of healthcare workers during this COVID. And to present this topic, we have Dr. Avinash Hosnagar, who has completed his psychiatric training from All India Institute of Medical Sciences, New Delhi, and Western Psychiatric Institute and Clinic from University of Pittsburgh. He's currently an assistant professor of Department of Psychiatric, University of Michigan, USA. He manages patients with severe depression, PTSD, and substance use disorder. Dr. Avinash, welcome to the show. This is our 62nd session. We will introduce you with a lot of representative of various countries after the presentation when they are talking about their question answers and giving their update on their particular country. Over to you, Dr. Avinash, for the presentation. You can share the screen.
Is everybody able to see the screen?
Thank you. Yes.
Yeah, great. First of all, thank you, Mr. Agarwal, and thank you, all of you, for having me present at your distinguished meeting. I'm honored to be able to present this. These are unprecedented times, and all of us are facing very unique challenges. I think over the course of this pandemic, you've heard of a lot of medical challenges, medical issues that people have faced with, system issues that you've all had to deal with. I'm going to focus specifically on the mental health aspect of healthcare workers here. There's a broader mental health challenge of dealing with a pandemic over such a long period of time that also needs to be discussed. But I'm going to be specifically talking about mental health of healthcare workers, which I think is really important. Being you all being leaders among your own medical associations in your respective countries. So I do think that you have a unique role in trying to promote mental health of healthcare workers in your own respective countries. So I don't have any specific conflicts. Let me just, is this full screen version visible to everybody?
Yes, better. Thank you.
Okay, great. So the objectives of today's talk, from my point for the next half an hour, is kind of review prevalence of mental health issues among healthcare workers during the COVID-19 pandemic, review factors affecting healthcare worker mental health in general, and review strategies for leaders to adapt to help reduce the burden of mental health issues in healthcare workers. So, prevalence. In a sample of about 256 healthcare workers from a university hospital in central Italy, this is from the early days of the pandemic, when the rates of COVID were going up pretty high in Italy. They found that females showed a greater a degree of secondary traumatization. Females were more sensitive to the news, to the idea of something bad happening, and were traumatized from the idea of getting COVID or the impacts of COVID. A study coming out of China found that the psychological distress was seen in nearly 72% of of the healthcare workers. Depression was prevalent in nearly 50% of them. Anxiety was prevalent in about 44% of them, and insomnia in about 34%. Liu et al. From a study in China also found that healthcare workers who feared infection in their close family relatives reported higher level of stress, anxiety, and depression. Uh, Magnavita et al., who specifically looked at what is known as a burnout syndrome, which is characterized by emotional exhaustion, depersonalization, a sense
Dr.
of.
Abhinav, can you just take the microphone a bit closer?
You're not able to hear me?
Yeah, yeah. Thank you so much. Now, so,
Is this better?
yeah, yes, better.
Okay, great. The burnout syndrome, which is characterized by emotional exhaustion, a sense of depersonalization, a sense of low personal achievement, which was measured during the previous epidemics/pandemics of SARS, MERS, and SARS-CoV-2, found that a third of healthcare workers experienced the syndrome of burnout, which is basically has been shown to result in lower productivity, people not being able to function as well, and people not reporting to work because of a sense of burnout. Uh, Partha Sarthi et al. From a study in India found that in a study of survey of 3,083 healthcare workers, found that anxiety and depression was highest among those with frontline COVID responsibilities. It was significantly higher among those with clinical responsibilities compared to those with supportive responsibilities. So anxiety disorder prevalence was about 23% in those with clinical versus 15% in those with non-clinical, depression being about 20% versus 14.2 in those who have non-clinical, which is much higher than in the normal periods of time when there's no pandemic going on. The rates of depression and anxiety is high among healthcare workers, especially among those who have intensive work, but this is much, much higher. And studies have shown this to be about nearly twice that of the normal rates in among this group. Singh et al. From a study in 2021, again showed that depression, anxiety, and somatic symptoms, which is basically reporting multiple aches and pains, GI symptoms, other neurological symptoms, were present in about 50, depression being about 54%, anxiety about 44.3%, and somatic symptoms were about 54.6% in healthcare workers, and especially those, it was much higher in those working in COVID-19 areas. Nurses and female healthcare workers, again, this is a trend that you'll see commonly, that female healthcare workers tend to have more significant, moderate to severe somatic symptoms. And this is of particular concern because female healthcare workers provide a lot of essential frontline healthcare services. Nurses are seeing the most number of patients, and to understand and to kind of respect that is going to be important, because if we don't take care of their mental health needs, a lot of our patients' mental health care needs will not be taken care of. These healthcare workers use both maladaptive and adaptive coping strategies. Tan et al. From a study in Singapore found this was a study done among nearly 11,200 healthcare workers, found that burnout thresholds in the areas of disengagement and exhaustions were met by nearly 80% and 75% of the respondents. That's a very, very, very high number of healthcare workers in even places like in Singapore. In those who had high depression and anxiety scores, it was found that shifts lasting more than 8 hours being redeployed were significantly associated with higher mean depression and anxiety scores. In a study from Nepal, which found that 41%, nearly 40% of healthcare workers had symptoms of anxiety, 38% had symptoms of depression, and about 40%, 35% had symptoms of insomnia. So what you'll see is this is, and I've kind of focused on studies coming out from Asia to show that this is a common issue for healthcare workers in Asia. This is a common problem. This is seen in nearly 40%, 40 to 50%, depending on the study rates, that you will see depression, you will see a lot of anxiety, and you will see a lot of insomnia. So your healthcare workers are experiencing this, and this is something that you leaders need to be mindful of, so that it can be adequately addressed. A systematic review, which is the largest kind of study in the field right now, they found that that prevalence rate was about 23% and anxiety was about 22%. Again, this is just from across all different studies from 13 studies that they looked at. Majority of these studies were coming out from China because they were earlier to report, but there are newer studies coming out from a lot of other Asian countries, including Vietnam, Thailand, Malaysia. And so we will have more data in the future, but I suspect the trend is going to be not very different from what we're seeing right now. So what are the mental health factors? What are the things that we need to think about in terms of psychological responses during a disaster, during a pandemic? And these kind of hold true. And so some of these models are based on disaster psychiatry. And so in an early phase of during the period when the cases are going up, there is a fear for basic needs. This is true for everybody, and it's especially true for healthcare workers. As we plateau, there's an uncertainty of how things will evolve. And then when things start coming down, we feel better, but there's a whole lot of processing that needs to happen of that traumatic experience that people have experienced during the period of stress, during this acute rise in numbers. Sorry. People go through these emotional highs and lows during the early period. This is a Johns Hopkins model, which talks about this early period when there is the impact and there is a lot of heroism. People step up. There's a resilience. There's a honeymoon period. Community comes together. But as the pandemic goes on, as it stretches on and on, a period of disillusionment comes in. This is when the emotional lows happen. There are ups and downs. And then people get to this period of restoration, which is very gradual and slow, where they have to work through their grief, they have to adjust to this new lifestyle, new situation, and rebuild and get back towards that normalcy. So there is this period of, initial period of strengthening of psychological and behavioral immunity, which is followed by helping with the rebound process and supporting recovering and moving on. During this process, another way of also looking at is that when during this disillusionment period is when people experience a lot of negative symptoms. So there are a lot of trigger events that happen, and there are a lot of anniversary reactions that happen, and that itself can bring about a lot of trauma, bring in a psychological trauma, and begin symptoms of anxiety and depression, which may not have manifested during this heroic and the honeymoon period. So one needs to be mindful of that, especially during this period. So during big disasters, you'll see these big areas. One is of distress reactions in the form of sleep difficulties, anxiety, somatic symptoms, irritability, anger, distraction, and isolation. Also, during this period, you will see some health risk behaviors. People will start engaging in behaviors that are risky, which is people will start using more substances. So there's a greater alcohol consumption to cope with the stress, to cope with anxiety. They'll start smoking more. There's a greater family distress that you might see. You might see interpersonal conflicts and violence. And there's a big disruption in the work-life balance, especially in the context of restricted activities and travel. There is a smaller number of these patients, of these people who will experience some kind of psychiatric disorders in terms of depression, anxiety, complex grief, and PTSD. But it's also important to remember that there's a big resilience piece that happens too. People find their own inner strength, and community comes together, and we get the best out of people during trying times. And this is what helps people cope. And so, this is an important factor too that we need to be thinking about as we deal with a pandemic like this. So, COVID 19 has brought about unprecedented challenges. So, there's a high demand for medical services, not just acutely, but over a long period of time, which puts uh, a significant amount of stress on the healthcare resources and the setting and the staff itself. So, we've been in the midst of pandemics since at least the official declaration since the February, March of last year. So, it's been over 13 months that this has been going on. People, healthcare workers have been forced to step up into roles outside of their own expertise. This includes not just the clinicians, but non clinicians as well. But people who have no experience or expertise in managing certain disorders have been forced to do that. I can talk about, I know of cases of across in different countries where, uh, psychiatrists, dermatologists, people who do not have necessarily the medical kind of experience have been managing patients with COVID. Patients, general medical, family medicine kind of practitioners being forced to manage patients with COVID because there are no resources available. So, people being forced to step up into these roles outside of their expertise is an important consideration. There are uncertain and evolving protocols for managing COVID 19. At one point, a specific protocol, a specific treatment strategy is said to be the gold standard. A few weeks later, a different strategy becomes the gold standard, and it's constantly evolving. The evidence seems to be coming from so many different resources, so many different places, and news media that we kind of lose track of what is the best way to manage patients. We healthcare workers have a very high fear of contracting COVID 19 because of the degree of exposure. And more importantly, many of them carry the fear of spreading it to family members, co-workers, and their patients. And in many countries, the healthcare workers have had to live a life of isolation away from their own family members. So, this normally their family members would be sources of their strength, sources of support. For many of those healthcare workers, that has been taken away. So, that's an important consideration that we need to be thinking about. As healthcare workers get infected, get sick themselves, or experience high degree of burnout because of the volume and the degree of work they're involved in, this can result in absenteeism and staff shortages because workers are staying home. When healthcare workers have been surveyed on their sources of anxiety, they identified these main sources of anxiety. Having access to the right kind of PPE, that is personal protective equipment, which may not be available all the time, may not be, most Asian countries are developing, and so they maybe have limited resources to PPE, and so that is a big issue for healthcare workers. Exposure to COVID 19 at work and taking this infection back to their home, to their families. Last, the lack of fast access to testing if they did develop COVID 19 symptoms, and uncertainty whether, uncertainty whether their organization will support and take care of their own needs, and more importantly, their family needs if they were to develop some kind of infection. Support for transportation, food, and other personal and family needs as work hours and demands increase. Access to childcare when extra working hours are involved. Having the right skill set if sent to work in a new area, such as a floor nurse who's sent to work in an intensive care unit, and lack of access to up-to-date information on management of this illness and communication about it. So the APA experts on the principles of disaster management has suggested, which is the American Psychiatric Association's expert committee has suggested that it's important to recognize that exposure to death, especially when it's in high volumes, it's important to recognize that this is an extreme stressor for healthcare workers. Healthcare workers face challenges of workers with less experience in intensive settings, inadequate base of treatment, as we just talked about, insufficient resources, including lack of optimal self-protection, which you talked about, obstacles to meaningful connections with patients, where their interactions with patients become so brief that the basic doctor-patient relationship may be lost, and decreased access to the healthcare worker support system, such as families. Uh, so one of the things that has been advised is to apply this principle of a psychological first aid among healthcare workers, which is to promote a sense of safety as best as possible, that making sure that healthcare workers feel safe, um, helping them use self-calming techniques, and this we can get into a little bit more in during the discussion. Promote basic self-care like food, hydration, rest periods, sleep, and exercise. During the midst of a pandemic, as we are seeing the high volume, it's very easy to forget about our own self. We all hear about this in the airplane that, before you put on a mask for someone else, if there's a oxygen pressure drop, you need to put on oxygen mask for yourself first before you put it on for someone else. This is very important for healthcare workers to realize that they need to take care of their own food, hydration, rest period, sleep proactively during this pandemic so that they can help not only themselves but others as well. Unfortunately, during the midst of stress, it's very easy to forget some of these basic things. The other thing that's shown to be helpful is encourage use of prior helpful coping mechanisms. So things that have helped you in the past, thinking about them and utilizing them during these periods of stress. Access to stress reduction resources like online resources like yoga apps and other things can be helpful. Creating a sense of team and connection between team members. There's a very high tendency to feel stressed and not talk to others and feel overwhelmed. But a team cohesion and talking to other team members actually helps bond and helps team members work better. So encouraging some of that is something that leadership should be actively be involved in. Providing social supports, helping support self-efficacy, and then identifying and monitoring those in high distress to get appropriate additional mental health team support for these folks would be very, very important. So how do you cope and manage? We talked a little bit about that. One of the things is very important to acknowledge is that death are occurring, and that death and challenges associated with managing death is a big concern. Stress is heightened by heavy workload, as we talked about, inability to follow the usual routines that we are all used to, and having resource supports from family members or others is going to be important, and one needs to recognize that. And we need to help healthcare workers to acknowledge the impact by talking about these stresses and recognize and honor the efforts of all the work that the healthcare workers are doing. It's very important to recognize the healthcare efforts on a regular, periodic basis. I personally feel this could be in small teams on a daily basis, in larger groups on a weekly basis, and at an institutional level, at least in a once in 2 weeks or a monthly level, so that people feel a sense of achievement, a sense of a belonging, and a sense of a higher purpose that can be achieved by some of this recognition. One needs to also be mindful of individual differences in responses to death. Some healthcare workers will talk about it, others will not. They will shut down and they will kind of internalize it and experience their own depression and anxiety without talking about it. So understand the differences between these individual responses and suggest coping mechanisms to manage these individual responses. So what can the leadership do? So one of the things that leadership needs to do actively is to respond to the healthcare workers' needs and their concerns. So these concerns can include uh, workers without the needed personal protective equipment, workers witnessing human suffering to the extent that they have not ever witnessed before, making life and death decisions and making decisions on who should get that resource at any given point in time and who shouldn't. And that brings about such a significant moral dilemma that can affect healthcare workers for the rest of their lives. So this is something that people need to recognize. A fear of infecting family members, separation from family, and fear of getting sick, and, a, and the healthcare workers' mental exhaustion. How can you help them? How leaders can help them with modeling behavior. So if wearing masks is an important piece, then leaders should be doing that at all times so that the rest of the team can follow that. And this is just an example. There could be other behaviors that leaders should be doing to model behaviors that can help the rest of the team. We need to listen to healthcare workers. We need to protect them. We need to prepare them. And some of this preparation can happen when the numbers are down. So some of you were talking about how the numbers in your own country are down. This is the time to prepare. This is the time not to be inactive, but to be proactive. This is the time to make sure that if that situation were to ever arise in your own country, your staff is prepared, and that will help reduce the mental health burden. And when the numbers actually go up, be quick to support them and be quick to care for them. Things that help healthcare workers is to talk directly with your staff and listen to them. Be a servant leader, being part of your staff, being proactive with them. Walking the floors as a leader on a weekly basis to show support for your staff is helpful. Model the right way to taking off personal protective equipment if sometimes there is some degree of disagreement on whether they should wear a PPE or not wear a PPE. You can be a good role model to that. Setting up a buddy system, setting up a system where every healthcare workers has 2 or 3 buddies who can take care of the healthcare workers. So if someone sees someone else in distress, they step up and support their own buddy. So setting up that system in each hospital or a health system is very important. The next thing is to post and share tools and resources that are available for different aspects, whether it's the medical care or it's the mental health care. Kind of having an easy resource that everybody can access to and in a timely manner is going to be critical. Giving support to healthcare workers and their families is very, very important. And this is something that leadership within the health industry need to talk to leadership outside of the industry to kind of advocate for that, to make sure the healthcare workers get that kind of resource. And the most important thing is to communicate clearly as often as possible and let teams know what is going on. Keeping them informed is critical. Without that, people will feel left out and people will feel anxious because they will feel unaware. So the more you talk to your team, the more you make them aware, the more you keep them informed, the better prepared they will be to manage your patients with COVID-19 and other situations. So these are my references. I'm going to pause now. I think we are okay in terms of time, and we can start the discussion if that works for everybody.
Sure. Thank you, Dr. Avinash, for a beautiful presentation. listen to them, protect them, prepare them, support them, care for them is a very important message you have given for this. I would like to now invite Dr. Chong as a chair for this session. And before that, I would like to acknowledge the presence of obviously Dr. Chong from Singapore Medical Association, Dr. Ravi Kumar from Malaysia Medical Association, also the immediate past president of SIMAO, Dr. Professor Nazmi from Pakistan Medical Association, Dr. Elvin from Hong Kong Medical Association, Dr. Pillai from World Medical Council, Dr. Angelica from South Africa Medical Association, Dr. Jamal Chaudhry from Bangladesh Medical Association, Dr. Akhtar Hussain again from South Africa Medical Association, Dr. Sajid from Pakistan Medical Association, Dr. Hussain from Pakistan, Russell from Dr. Russell from UNESCO, Dr. Monica Vasudev from USA, Dr. Nidhi from USA, Dr. Sanchita from IGCP Group, Dr. Meenakshi from Heart Care Foundation of India, Dr. Shashank Joshi, endocrinologist, India, also a very important task force in Mumbai, COVID task force. He was preparing. Regrets received from Deborah from Brazil and Mary from Japan. Over to
Dr. Alvin.
Hello?
Yeah,
Hi.
over to Dr. Chong.
Hi, everyone. Can you hear me?
Yes,
Loud
yes.
and clear.
Thank you, Dr. Avinash. Great presentation, very close to our hearts because, even I myself felt so much stress over the last year dealing with, COVID. And we had a similar experience in Singapore with SARS in 2003. So it was a bit of like a PTSD, if you know what I mean, because we had to go through it again. So perhaps I have never heard of this Singapore study that you brought up, but I think one of the reasons why the rates were so high is because we had a rerun, a rehash of 03, especially a lot of us in the senior leadership who had seen the 03. Of course, we were better prepared this time, but nevertheless, it was quite traumatic for us because the first time around was terrible. 03 was incredibly challenging, and I'm sure Elvin will tell you that as well. What happened in Hong Kong and Singapore was terrible, and we had healthcare workers perish on us. A few doctors perish, a number of nurses perish. It was really, really dark times. And I remember we were scrambling for N95 masks. We've never heard of N95 masks at the time. So what you've said to us is actually very real to us out here in Singapore and in Hong Kong, probably. Brings back terrible memories. So today's topic is very important, I feel, and it is rightly a good topic. So without much further ado, let me open up the questions to the floor. Whether everybody has any questions for Dr. Avinash, great presentation. Thank you.
Dr. Chong, I'd like to ask a question. Dr. Avinash, thank you for that excellent presentation. I'm Russell D'Souza from Melbourne, and I'm from psychiatry myself. Work with University of Western Reggie Tandon from your Kalamazoo. Works with it. One of the things that we've been talking about, all what you brought in was absolutely what we've seen. But one of the important things that have come out, particularly from organizational psychological medicine, is a new phenomena of distress and moral distress and moral injury. Okay, now if you look at a couple of studies, there's an Italian study, again, bringing this area, then there was a Chinese study, July 20, I can give you that, and then there's an Indian study by Gupta in August 20, all showing the highest of this pathology that we're talking about, anxiety, depression, usual insomnia, which is what we usually see. But all these three have shown significantly moral distress, and moral distress then leading to moral injury. Okay, now this is an important new area because moral injury for psychiatry has only been known in the past from the return from the military, from army, or from the war return. But this is the first time that we're going to see moral injury in healthcare staff. And one can take that. Another important area that's come up from Berlin, from living at all in Berlin, is it's the papers when stress makes you bitter. Embitterment disorder, post-traumatic embitterment disorder in healthcare workers. This is again published in the Psychosomatics in 2020 by Linden from Berlin. So bitterness arises from situational life events that are perceived to be unjust threat to person's specific. The reason I'm saying this is, particularly from Dr. Chong and others who faced this issue in Singapore, certainly in the way at the moment, looking at moral distress, and moral distress, moral injury, toxic stress is the other part. Toxic stress then related to all the inflammatory processes and so forth. So one of the new things that has come up that we've identified has been not been, but everyone, we're doing one at Manipal at Manipal Academy of Health day, and they were looking at moral distress, moral injury in the Indian scenario where the health workers. So that's something new, I think, for all of us here to know that there is a thing called moral injury and moral distress. A lot of it is there I saw with studies with American nursing. They talk a lot about the moral distress, moral hazard, and its implications on ultimately work life and ultimately function, or outcome. We're looking at the productivity. That's what I just wanted to bring out here. Very important that we've only seen this now in other disasters. Certainly, we do see what all this what we've described, but something new has come out here, and this is the impact of moral distress, moral injury, toxic stress, and Linden's work in Germany on embitterment, becoming bitter. So the workforce and they call post-traumatic embitterment disorder applies to a person experiencing, witnessing, or even being directly confronting with highly traumatic events, the loss of significant others, serious illness, disability, and so forth. Thank you. I just wanted to add that to the wonderful presentation that you brought, and this sort of brings in some of the areas that we are beginning to see, and I'm sure many of us here who have been dealing with this disastrous pandemic will be able to identify this set of issues. Thank you.
Thank you, Dr. Russell.
Thank you, Dr. Russell. I think you bring up a very important issue. I didn't get into very specifics of the psychological distress that patients experience, but the moral injury and the moral distress and the post-traumatic embitterment phenomena that you're talking about is very true, because this is, like you said, is often an ethical internal dilemma that one faces in certain maybe life-threatening situation which service or army veterans experience when they are in war and they have to make certain decisions. We've as healthcare workers have, for most part, have had resources and have had decisions to make based on general principles of what we've been taught in medical schools and in our practice. But this is the first time where we are forced to decide: do I give this oxygen cylinder to a 45-year-old man, or should I, who came later on, but should I give it to a 70-year-old man who came here first, right? He came to the hospital first. Who gets this oxygen cylinder? Whose life do I save here? And if I do it, or if I don't do it, either way I'm wrong, right? I'm damned one way or the other. And so that brings about a significant moral injury to you when you make that decision. And that brings about the embitterment feeling that you talked about. And I think that is very a very powerful thing that all of us healthcare workers are experiencing. We've talked about that in the past in psychoanalysis in the past, but this is a phenomenon that we are becoming more aware of as we are experiencing this. And kind of, it's a very important phenomenon that we need to understand, that this moral distress we will carry over, not just during this period,
Yes.
but beyond this period as well.
And I think that's the important part, that toxic stress is now related to inflammation and the issues about oxidative stress, which goes on to affect, virtually all the just what you said was beautiful. Just all of you here, just to have an idea, and I think we can all relate to this. Imagine being a healthcare provider required to triage, as Dr. Avinash just said, COVID-19 patients. You're inside a crowded emergency room, deciding which of the two patients will get to your emergency rooms, only remaining ventilator. Although you understand the situation requires you to give the ventilator to the person with the highest odds of survival. That is, as you just described. Yet, we were not trained to make this kind of decisions, as you rightly said. So what happens? You have always had resources to treat patients, but in this scenario, both patients died, despite you having put one person on the ventilator. Okay, now you wonder whether you made the wrong decision. Could the other patient have survived with that ventilator? You are wrecked with guilt, replaying that scenario over and over again, analyzing how different choices might have created different outcomes. Your distress becomes overwhelming, so you bury yourself in work. You put the pain but the pain follows you back home. So now you take it back to your home. You avoid conversations with your family and peers. You distract yourself at the expense of routines that were once meaningful. And you tell yourself that you followed all the protocols, did the best you could, yet still you violated your moral values. Now, this is precisely the context in which moral injury may develop. Now, this is why this is unique, because we are faced in this pandemic. We put all our colleagues, all of us have been put into this type of situation. And that, and as you said, little is known about moral injury in non-military populations. But this pandemic has made it clear that moral injury has relevance and extends beyond the battlefield. And in fact, all of us here on another battlefield. That's it. Thank you. I hope we've been able to, Dr. Avinash and whatever, expose what moral injury and how that works. And this is something new only in the last 2 years that we've started to identify this outside the battlefield and in the healthcare workforce around the world. The studies are showing China, India, Italy, UK, and we got some work from UK too on this area. Thank you very much.
Mr. Chairman.
Yes, Alvin, you have something to say?
Yeah, can I join the discussion? It's a very meaningful discussion with Russell and Dr. Avinash. In fact, I really agree with what you have said. And so that's why I'd like to ask Dr. Avinash as well. Are there studies that have separated the objects as nurses and doctors? What I mean is, in fact, from the, say, moral injury or the things, doctors are the ones who more often have to make the decisions. We have to make the choice whether nurses will have to follow our instructions. They might have less trauma in making their own decisions when it's the doctors who has to make the decisions. Very often, the nurses have to ask the doctor, what should I do? And what should we make the decision? And we have to give our advice. So I think in my past days in the hospitals, working in the hospitals, we often are looked upon by the other healthcare workers. And then we have to really stand up, lift our heads and say something. But then we have to be responsible. And I think we are vulnerable to the toxic effects of such moral, stress and injury. So I just wonder, in the presentation, Dr. Avinash, most of the studies seem to be studying on healthcare workers. not really just doctors? Are there studies just focusing on the effects on doctors? This is a first question. And the second question is, well, in your last second slide is on coping with these situations. Can you please later on show the slide again? You just flash it, you know. And I think in real life situation, leadership, how we should, those principles are very important. And but facing the real life situation, how are we going to make those choices and the decisions with the decision making? What I mean is our personality differs. Different people have different personalities in the background, and that would make us, some people like surgeons, they would make decisions much faster. You know, internal medicine, pediatricians, we have to think over and over and make the decisions. All right, these are different personalities, but in the real life situation, like in those hospital laws, lack of oxygen masks and syringes, we have to make very brisk, prompt, and instantaneous decisions. So different personalities might give us different problems. So are there studies analyzing on our different personalities that would make us more vulnerable in what situations? So these are my two questions. Thank you.
Thank you, Avin.
Of course, so it's also a psychiatrist. Of course, you also have studied on many of spiritual aspects of how to deal with these situations. I don't know whether there are also such
the studies
as well.
When you look at what's available, I was looking at a couple of things. Treatment programs promoting early intervention, as I said, developing tailored interventions, but they've shown some work on acceptance and commitment therapy for mortal injury. Boards in 1920 and Farnsworth took their studies. Spiritually augmented cognitive behavior therapy, again, shown some benefits. Adaptive disclosure, Gray et al., again, some benefits. So these are some of the ones, but it's very new. So we haven't got to that extent. But answering your question, I don't know what Dr. Avinash might know, but I saw this one study by Gupta from India that actually looking at the symptoms. Where I talked of the three, Italy, China, and India. But in that study, well, of course, health distress, perceived distress, burnout, these were there. Post-traumatic stress, anxiety, depression, insomnia. Perceived stigma was the only one in the Indian study. The other two studies didn't have stigma, but the Indian study, a Gupta study in August 2020, talked about stigma, and in that study they showed nurses were the most common population of the study, followed by doctors. This is the Indian study from Gupta. That's the only one I've seen, but Dr. Avinash might have other to differentiate between the different disciplines of healthcare providers.
Thank you, Dr. D'Souza. Dr. Avinash, maybe you want to answer Alvin's questions?
Yeah, so thank you, Dr. Allen, for your question. So first of all, most of these studies have been carried out in general healthcare workers. They have done some subgroup analysis among doctors, nurses, and other ancillary support staff. So while the data, the most robust data is actually among the nursing group, more than the doctors. There's a nursing group. Most of the data that we have is actually in that group. Unfortunately, we don't have that data based on specific specialties, like you talked about surgeries versus internal medicine, which is, you're right, in terms of a mindset, a surgeon needs to make quick decision. In the ICU, intensivist will need to make quick decision versus someone else, a nephrologist in a non-critical situation will make a more thoughtful decision. But I think the important thing to remember is, no matter what we do, we as healthcare workers, especially physicians, take on far greater responsibility, or have a sense of far greater responsibility, or feel that we have far greater control over situations than we actually have. And so we take far greater ownership, and therefore we bring on far greater moral injury. So, and this is the more decisions you make, I think the more moral injury you are going to experience. So you're right in the sense that a nurse may not have the same degree of moral injury kind of experiences that an intensivist or a surgeon or anyone else might make, but a nurse may have a different kind of anxiety being in the room with the patient more number of hours than a physician is. Physician is in and out of the room, so they have greater exposure to the virus, right? And so the greater chances of getting infected. So their fears are different and their anxieties are different than the moral injury kind of anxiety. So all of us experience, as healthcare workers, experience that, but in a different domain, but it all adds up because a nurse's anxiety will lead to that burnout. A physician's moral injury will also lead to that burnout. Ultimately, all of that will result in poor productivity. So, in a sense, we have to recognize this across the board. Yes, as physicians, we are faced with some unique challenges in terms of decision making because we are the team leaders. People look up to us for decision making. And therefore, that makes a big difference in terms of challenges. So in terms of studies themselves, there are very few studies which have identified specifically looking in physicians. They generally talk about classify as health workers in general. There may be some subgroup analysis, but I'm not aware of every subgroup analysis that has occurred. To kind of answer your question specifically in terms of numbers, like I said before, greater number of studies done with nurses and other healthcare workers, just because it's easier when you survey out, there are far greater nurses than number of physicians available. So then their number of responses is going to be much, much greater, right? But there are unique challenges and unique things that happen to each subgroup, but each subgroup suffers in their own way, and we have to recognize their own suffering.
Thank you, Dr. Avinash. That was very, very insightful. Interestingly, we all must realize that medicine is an imprecise science with variable outcomes, and so we think we're in control, but actually we're not. And that is something we have to live with. And I think in battlefield, probably there is a difference between the officer and, for example, the non-commissioned officer class. So likewise, perhaps there's a difference in physicians and the doctors and the nurses' roles in a healthcare system. So perhaps different roles have resulted in different sort of stresses and reactions and so on. But certainly something interesting to study. I mean, the differences between physicians and, let's say, nurses, because I can imagine on the battlefield is also quite different.
I want to just add one important part here in terms of our own beliefs of what the extent of control and power we have as physicians. We like to believe that we can impact and make a lot of changes, which is true. But we also need to recognize our limitations, because a significant aspect of what we do depends on the resources around us. So it depends on the number of people who are vaccinated around us, the PPE that is available, the intensive care units that are available, the oxygen supply that is available. While we think that we have control, we don't have control over a lot of these. These are system issues that we are facing, but we face the moral dilemma because we are ultimately at the end making those decisions. But these are far beyond our own control. These are decided by countries, nations, based on their own economic status, where they are at in terms of development, their own access to resources, and what is their own priority, right? So that makes a huge difference. But we all like to take control. We want to be in charge. We want to take control. At the same time, we also take responsibility for things that are not necessarily our responsibility. And so that's very important for us physicians to recognize as well.
Yeah. I
May I say, Mr. Chau?
What you're saying is absolutely true. But one of the unique things in this situation was that economically developed countries like USA or Italy or UK had to face this, even though they had resources, they had a shortage because of the pandemic. And that's why many of them who are never used, maybe someone in a rural place in India or somewhere might be able to have less because they're every day having to deal with less resources. But we talk about it happened even in Australia, where when you suddenly have to no beds, you don't have ventilators, you don't have oxygen, where you're used to having everything. That is one of the uniqueness of and that's probably the reason we saw this across so many countries, particularly in the developed world where this happened.
Thank you, Dr. D'Souza.
Sean, can I say something?
Ashraf, yes.
Yeah, thank you very much. Thank you very much. Thank you very much, Avinash, for a wonderful presentation. I'm Dr. Ashraf Nizami from Pakistan. I would like to know and share my experience. Hence, I have been honored to be working in a country where the Chernobyl in 1985, if you people remember, that was the disaster, the first main disaster after the Second World War. And I have been also volunteered in Pakistan in 2005 when there was the earthquake and 80,000 people, they have the loss of their lives. One thing which I understood, I'm orthopedic surgeon by profession, so you can understand that what the team work and the captain of the team can decide about all that. And having the team from Lahore to the places over there, about 100 and plus health workers supporting in the earthquake in 2005, what I got and understood and learned from all these health professionals, stress syndrome, that maximum threshold, it is in between 7 to 10 days. And we make a routine that the health workers who were serving at the earthquake place, we used to change them, shift them after 7 days and so on. Here the same in COVID-19, I believe it is more disastrous than any war what we have faced over here. And with all my respect to Professor Russell, I believe it is not about the have and have nots. It is about the question of the health system. What my belief is that the COVID-19 has not destroyed the health system. I believe it has exposed the destroyed health system, to my understanding, what I believe. And I have a firm belief on it. My question to Avinash, with all my input and so, did you find any impact of burnout syndrome on family or population, if any study or your personal experience about it? Thank you very much.
Thanks, Prof. Ashraf. And I think you made a very good point here, Prof, is that the moral injury is worsened when the healthcare system is overwhelmed. So all the things that politicians and society had to do was to prevent the healthcare system from being overwhelmed. But once it was overwhelmed, the moral injury was massive. And that's why we didn't have much control over the situation, if you know what I mean. Because it was the politicians and the leadership of the countries that usually decided and ended up with such a situation. So unfortunately, we were at the receiving end of the stick. I welcome any other questions for Dr. Avinash and Dr. D'Souza.
So, Dr. Nizami, I just want to take a minute to kind of, first of all, acknowledge what you did in back then, your efforts in 2005. That is something to be acknowledged in this group, if not in the forum. So thank you for what you did back then for all the people. It was a huge humanitarian crisis, and thank you for stepping up and doing what you did. So just going back to your specific questions, if you can just repeat that question again for me, what was that you asked?
Thank you very much, Avinash. I just asked about it, that the impact of this burnout syndrome upon the family or the society. If you have any studies about that. Thank you.
Yeah, so unfortunately, we have no specific studies that I'm aware of that have looked at burnout syndrome and its impact on family members and the rest of the society. But in terms of this COVID-19 specific situation, but there is enough study about burnout syndrome and impact on work and productivity for hospital system, and therefore its overall morbidity and impact, the economic impact and general impact on the health system, that we know very well. So burnout system results in a smaller workforce, It results in people choosing careers that they may not have. It results in people choosing other profession outside of medicine that they tend to value more than they would have otherwise. And it leads to less uh, less I'm trying to figure out that less uh, productivity in the work on a day-to-day basis. So all of these have impact in the number of patients we see, the quality of healthcare we provide, and the outcome on these patients. So there's a huge economic impact of this burnout, and this is where there are there are a lot of studies on that. There is impact of burnout on mental health of the individual. That is well studied as well, and that's immense. What we don't have is a specific study looking at impact of burnout and family member impact with COVID, or in terms of overall productivity. So just to give you a general sense of what burnout field looks like.
Thank you. Thank you.
Can I ask the question?
Yes, Dr. Bukhari.
Oh, thank you very much. I'm Professor Bukhari. In continuation of Professor Nizami, he is our leader in PMA, no doubt. The same experience that I felt last year when we started, I am pathologist basically. When we started the COVID lab, it was very difficult to take the sample. And I myself was afraid that nobody was going to take I was the first person to take the sample from the nasopharyngeal swab, and you cannot imagine what was my condition. Anyhow, basically, this mental health problem was created by the media. And one thing. Second thing was the COVID was just a new thing, and we all were not prepared to how to face it. Like the Professor Nizami has told that the COVID has exposed our healthcare system. And the one of the difference that in Pakistan, I felt this mental health care panic was more present in the females as compared into the male. So my one suggestion and one question. My one suggestion is that in the future we may face similar type of problems like in Pakistan we faced in earthquakes and some other things. I am there living there where the Professor Nizami mentioned. I'm principal in Azad Kashmir Medical College, where the basic site of the earthquake was. So my first suggestion is that we should have a conferences. We should have a just like a military trainings for our healthcare workers. Especially, I see our doctors were more afraid, more panic as compared to our nurses and other paramedical staff. So this is one suggestion. Second suggestion is that my question is that is there any difference between this panic activity in gender, or it is just a country to country difference?
Dr. Avinash?
Yeah. So the thing is, it is not necessarily identified by female gender. So it has been identified by different subgroups in different population. Now, majority of nurses tend to be women, but it doesn't mean that this is a situation unique to women. It is a situation that nurses experience, and that may be because of their level of education and their knowledge of medicine compared to a physician's knowledge of medicine. So I don't think it's necessarily a gender issue. It is an issue of knowledge based on where one is at in terms of their training and what they understand and how they process that information. I think that you're absolutely right that the media has a big role to play in terms of both having a responsibility
Very
in terms of
good.
kind of directing our overall well-being. Unfortunately, media will present what most people will read, or most people will kind of hear about, right? So they will sensationalize a lot of things, even if it is of low incidence, even if it has very low importance, which many of times create panic, right? Panic situations. So that doesn't really help people. So one of the things that I actually tell people is to shut down their time that they spend on news media. To kind of restrict it to as few hours as possible during these times, because that is not coming from experts. If you want expertise, if you want specific medical information, I tell them talk to your doctors. Don't listen to the media, because the media is giving you very sensationalized news to a factor. They might highlight a few important things, but they are not telling you what is. They do not have the medical sense or the knowledge to give you a nuanced understanding of what is going on, which only a medical provider can give. So, which is what I say: talk to your doctors and not to your news journalist for information. Your doctor will tell you exactly how to deal with that. And I think all of you can relate to that. You've all heard news situations which are completely out of order and make no sense to you. And when you actually read the actual information, you realize, oh, that's just 10 or even 5% of what the actual event was. And we maybe need to calm the situation down. So you're right. I think there is a responsibility for the media to kind of reduce the panic, help people cope. There's a so a lot of negative news gets information, but the positive news, the resilience news, gets put in the background. I think the media should be actually talking about the resilience, talking about the good things that people are doing, because that will help people endure and manage these situations better. So that's that's generally what we see with media and how people process information and manage situations.
In the same continuation of my second question was, how should we prepare our healthcare workers if such type of pandemic or such type of disaster in the future?
Hello.
I'm sorry, there's some background noise. I hope people are able to hear me. I think so. So I think if we don't learn from this pandemic, I think we all would lose as humanity. I think we owe it to our children to have learned from this pandemic and prepare the next generation for this. I think we need to, as every single society in this world kind of needs to take note of what happened. What did we do wrong? We talked about how it exposed our health systems. Now it is a responsibility to get our health system where it needs to be for future situations like this.
Exactly.
And not just the situation of an infectious disease like this, but other situations too. We have disasters happening all the time, but we pay attention to that for a short period of time and then we move to the next disaster. But we don't work on things proactively. So we owe it to ourselves to kind of get prepared, being prepared, educating, kind of running drills, mock drills to kind of deal with the situation, so that when we here in the US at least run fire drills. When we have every hospital system runs fire drills because they prepare for fire. I think every system needs to do that for eventualities like this at least once a year. What would we do? How would systems respond to disasters? What were the steps that we need to get in terms of disaster management, resources that we need in place? So this requires planning, not just from physicians, but physicians should be, if there was ever an opportunity for physicians to take center stage and demand more, it is now. For us to ask more of our leaders to provide those resources so this kind of thing never happens again. I think leaders around the world know that a single virus shut the entire world down, right? And if we don't act up now and get our act together to get the level of healthcare to the place that we need to, they will never do. And so we need to seize this moment, get more education awareness among the people, because only when they do something will our health leaders do something. So that, I think, is an important piece, I would say, that we should have learned from this situation. That's my own personal
you so
view.
much.
I don't want to
Thank you so much.
say that it's from from anyone specific or any organization. That's my personal view. I want to make that very clear.
I think, Avinash, thank you very much. It is not only your personal view. These are the normal standards. These are very much normal standards, and we have to abide by. And certainly we go on learning whatsoever that comes over. And from the wars and from the peacetime, we learn. And it is never ever to prepare for the bad days, but preparation needs to help the community. That is the best thing, I believe. And thank you very much, Avinash, for wonderful your sharings. I must appreciate your efforts. Thank you.
Dr. Bukhari, just because you spoke about media, Professor Rizwan Taj from your PIMS in Islamabad has published something on your media. He is here from Dr. Professor Rizwan Taj. He's at PIMS in Islamabad, the dean and the head of psychiatry. He has published a paper on media and its impact and things like that. It's just for you to, since you brought that up, I thought
Thank you.
Well,
Yes, hello.
discussion. Yes, Dr. Sajjad.
Yeah, thank you very much, Mr. Chairman. Dr. Avinash, it was very informative presentation. I must appreciate. I just second what you are talking about the media. I'm totally agree with the what you said about the media. But the problem is, how can you guide the media, particularly the electronic media, and we cannot control the media. Because in Pakistan, and I saw in the different maybe other countries, instead of doctors, the other people are talking more about the coronavirus, like the politicians, like the other businessmen, the other people, and they are horrifying the situations. So these are to be controlled. Otherwise, this is create a more mental problems to the healthcare worker as well as the general public, and we are facing all these nowadays. Thank you very much, sir.
Thank you, Dr. Sajjad. And Dr. Avinash, any response from you?
Yeah. So I know there are political tones to this, and I don't want to go towards in that direction. But all I want to say is this, that I think along with our roles as physicians, we also have a role in terms of being leaders in the society because of our knowledge base, because of our experience, and based on our strengths. I think the one thing I would say as a psychiatrist is to recognize that there will be a huge mental health impact, not just for healthcare workers, but beyond that, for the whole population. If there was ever a chance for people to understand that, everybody will recognize and understand that. So this is an opportunity for us to be more to be advocates for ourselves. Spread the word. People will listen to you. This is a good moment for us in terms of getting some of this work done and advocating for resources that we need for medical care, for mental health care. I think that is important. It can be done in so many different levels. Let us all be proactive within our own medical societies, organizations, to kind of get that message going towards that well-being, a better place that we want the world to get, right? So all of us have to do a little bit and maybe step outside of our own comfort zone, our own anxieties, to get to help people in the best way possible. So that is the challenging part. Each of us has, constraints, understanding, limitations, circumstances. But what we don't have control over everything, but we do have control over some things.
Absolutely, yes.
Things. and let us work on things that we can control in our domains. And you'll see that as you control those little things become bigger, and there are more things you can control. And accept what you cannot control. That will help you do better in things that you can control. So I think those are the things that you want to be thinking about.
Thank you very much, Avinash.
Mr. Chair, can I share one thing?
Yes, go on.
John? Yeah, thank you very much. Thank you. Avinash, thank you very much. But I think the media has very much significantly important role in our societies, wherever we are. Certainly, ethics come over here, and the training and the learning that comes. Here about the medical reporting, what we have done over here in Lahore, Pakistan, we have a University of Health Sciences, and we have started a diploma for journalism, for journalists, not for medical doctors, but for the journalists, and we have enrolled over them for the medical reporting without sensation. Meanwhile, there is a protocol and all has been made there. I'm sure university must be in United States or somewhere in the developed so-called countries. You must have also over there for the person who are deal with the media and so on. So this is what in Pakistan, learning from all the things what is we are experiencing, what we have started in Pakistan, in Lahore, a diploma by the University of Health Sciences. Thank you.
The same, Mr. Chair, same is here in Karachi, the university. They are doing the same thing what the Dr. Nizami said.
Thank you, Dr. Sajjad. Sarab, we don't have much time, right? The next meeting is coming in.
Yeah, I think the topics are going on and on, and this is a very interesting topic for everyone.
Yeah.
I was just thinking that we will take over the next session, but they will kill us, I would say. So I don't know if we have enough time.
Saurabh, one thing I
can
tell
have
you,
9 minutes.
can
Okay.
we have a role of media in medical sciences and such and this?
We will try to cover that. We
Yeah,
will try to
yes,
cover
yes.
that. We I think.
I'm sorry, Saurabh. Can I just actually,
Yes, Dr. Chaudhary.
yeah, sorry, actually, I had to go to attend the meeting, another meeting. So I just leave. So anyhow, I'm just so far I heard actually in between I could not just join. So far I heard actually the anxiety and the depression and the mental disorders. These have been compounded by the death of their colleagues also due to COVID, because in India and in Bangladesh also we have lost a lot of our colleagues actually, the medical fraternity people. So this also actually compounded their anxiety and depression, so that they get infected, they will not get beside the policymakers and others help like this. So I think this is actually compounding their distress actually. Thank you.
Thank you, Dr. Chaudhary. And yes, it's nothing like the fact that your comrades are around you that makes this grateful experience, and it's like a war. Okay, so I think today, in the interest of time, we don't have time for the country update because our next group of people are coming into the meeting shortly. But this has been such a fantastic, spirited discussion. It's obviously a topic that's very close to our hearts, and we never quite explored this topic before. I think this is the first time in 60 weeks. So, I think there's a lot of trauma, obviously, and distress that we've seen all around us and experience ourselves. And in particular, I would say that in Singapore, we had this terribly in 2003 with SARS. So this is like a flashback for us, in Singapore. But we made sure that we were prepared for this one. So likewise for everybody else, it's like a first time experience. So we can imagine the trauma you're going through because we went through it ourselves. So Alvin can vouch for that because Hong Kong and Singapore went through a really tough time. So I hear you that we have, as leaders of national medical associations, we have to make sure that we are heard, we have influence, we have the capability to push the leaderships in our countries to make sure we're well prepared for the next whatever comes our way, and not to have this this situation, this untenable situation of moral injury happen again. All right, I think this is our responsibility as leaders of national medical associations. So without much further ado, thank you very much, Dr. Avinash, for this wonderful presentation, and all the feelings and spirited discussion that came out of it. So
Thank you.
please let us have your slides, because we really want to have a good look at them and learn from them and perhaps spread our own message in our own countries. And thank you for bringing to my attention there was a Singapore study. I didn't even know about that. Thank you all, and we'll see you next Saturday. As always,
Thank you so much.
Great session, and we all look forward to next Saturday to meeting everyone. Thank you very much.
Okay,
Thank you so
very
much.
much.
Thank you.
Thanks.
Thank
It was my
you.
pleasure.
So just to make an announcement before, I think the next session probably we will try to bring on reinfection on a microbiologist. We haven't got the confirmation date, but I will announce in the group soon. And it's love to see the presentations and the topic of discussions are very meaningful to everyone. And see you next week.
Dr. Agarwal, I can talk on vaccine.
Okay, sure. We will definitely add those points over here. And Mr. Chong, I will discuss with you a lot of things offline. I think these presentations are going very well. Thank you.